Okay, so shall I introduce myself? So it's really good to be here with everybody this afternoon. My name is Julia Downing. I'm the Chief Executive of the International Children's Palliative Care Network. I'm a nurse by background, and I'm also a professor in palliative care in a couple of universities, and I have honorary contracts in the UK. So I know several people on the call, but I don't know everybody. But it's really great to be here with you today. And Duncan, over to you.
Hello, I'm Duncan Randall, and I'm Principal Academic at Bournemouth University. And some of you may know me from my publications. So 2016, I published Pragmatic Children's Nursing, a theory for children's nurses, about children and childhoods. And then I was co-editor on Alan Glasper and Jim Richardson's textbook, the third edition. And we're going to talk about the book that we've just got published a bit later. And so, yeah, so my background in palliative care really comes from the 2010 when we had the injection of money from the coalition government, and I've worked on things like the spectrum of children's palliative care and some research projects at Southampton Uni. So yeah, a number of different kind of projects around and about. Sue Neilson should be with us. Sue's not very well. Sorry, colleagues, but she's having dizzy spells, and so I can't think of anything worse than trying to do computer things and webinars when you're really not feeling that well, the world's all spinning around you. So Sue does send her apologies, but there we go. So if it's okay, we'll kind of launch into a bit more of the presentation, really. So, oh no, what if I do that? It won't be. So is that screen sharing all right, Julia?
Yeah, I can see it fine.
Great. So what we wanted to do was to allow a opportunity in time for people to kind of reflect on their own experiences of care, palliative care for children, and to talk about the standards that we produced with ICPCN that came from a all-party political party group, an APPG. So that work, was many of you were involved with as well, had led to education standards, and it led us really into the book as well, because we based the book on the standards that we were colleagues generated. So we'll talk a little bit about both of those things. Yeah, hopefully at the end we can think of some things that might help us to improve care, and so that's what we were hoping to kind of get out of it. And now comes the caveat. It's a huge area. We've just spent 2 years with our colleagues writing a book about all of this, and so and that was a big challenge. So we're not really going to cover everything to do with children's palliative care today. So what we were hoping to do was to really focus more on what we call core aspects. So these are really children's nurses, for every children's nurse, if you like. So it would be where you're looking after people where death is a possibility, but it's not the central kind of aspect of your work. So we'll talk a little bit about the levels in a moment, but if that's okay, we'll kind of try to stick to what all nurses need to know about palliative care. So we're not trying to do a specialist kind of crash course, and yeah, it's a big area. So we'll try and cover the bits that we can, focusing on core really. So we'll switch into this, which is Mentimeter. So this you can use the QR code on your screen if you're a smartphone is that way inclined, or you can just type in this code here, and that will take you into Mentimeter. and this is the code that you need on that. So I'll just give colleagues a couple of seconds to kind of do that.
Duncan, I've also put the link in the chat as well.
Oh, that's an excellent idea. Cool. So if the link's in the chat, I'll stop sharing that one and go into the other one, if that's okay. Technology is wonderful, isn't it? If it works. If it doesn't work, I'll be crying, but there we go. Cool. I think that should just be sharing. That should just be sharing Mentimeter now, I think, shouldn't it? If that's so. You've got some things at the top there, but
yeah, we can only see the Mentimeter slide.
Oh. Oh, there we go. So I can see people joining, you see down here. If you thumbs up as you join, then I'll know how that they're all piling in, which is always really helpful. The nice thing about this is it doesn't do anything to your phone. It's all done through the web, so as long as you've got a web connection, then you're fine. Let's give colleagues a few seconds just to do that. Cool. This is the illustration that's on the front cover of the book. That was an interesting challenge to get somebody to it's actually my sister-in-law who designed it, but it was kind of an interesting challenge to go to an artist and say, I want something that will portray palliative care, which and that's not their background. Cool. Okay, so if that's all right with everybody, we'll move into
we've got about half of the people on there.
Oh well, that's all right. No, you don't have to join if you don't want to. That's okay.
No, so some people might have got tied up with work pressures, Duncan. So
yeah, no,
that's happened before.
Yeah, not a problem. Thanks, Fiona. So we just wanted to kind of just start with reflecting, I guess, on our palliative care experience and what sort of 3 words would you put in there that would reflect on what you might be thinking, what you might be feeling. Fear and grief and support and living, yeah.
We've tried that Laura as well. He was on the TV. He didn't say anything, but it just seemed like the drop in Becky's face. It was just like.
Didn't quite catch that, sorry. Fantastic. It's great to see compassion central to that, and but there's a bit of fear and sadness in there, and nuclear. That's an interesting one.
Also, there's also dignity and memories and family.
Yeah, listening. I think that's nice, isn't it? Parallel planning's nice as well. Symptom management. Yeah. I remember back to the beginning of the Children's Palliative Care Education and Training Action Group, which we'll talk about more about. And we had an artist come and listen in to all of our kind of talk at the first meeting, and then they did this lovely picture, which was like it's in the report. Go and have a look at the report. But and actually, what they did was to capture really a lot of what we were feeling. And when we looked back at the end of the project, we went, "Oh, do you know what? That was a really good drawing." That's why we put it in the report, because I think it was these things which are not always easy to kind of express, and yet that what we were trying to do in that was expressed really well in that kind of artistic liminal space, which sometimes it's difficult to express in kind of research, quantitative, the things that we might be looking for is a kind of outcome measure from care, might be much more difficult to kind of trap.
Wait a minute, honey.
Cool.
Yeah, I'm doing a webinar on child development.
But also, Duncan, it's also, we see those key ones in the middle, but we also see that uncertainty. We also see challenge. We also see sort of a lack of knowledge, frustration. So some of the words at the outside of that word cloud are really important for us as nurses and as educators to think about. And how do we help nurses? How do we help the families in uncertainty? How do we build capacity and develop knowledge? And hopefully some of the work that we'll be talking about today will help with that.
Yeah, absolutely. I think uncertainty, that came through really strongly in the planning of the book, that we needed to help people to deal with uncertainty, because that's a major feature of palliative care work, is that predicting it is very, very difficult, probably not worth trying to do, so that you have to sit with your uncertainties. That hope, I think, is lovely in there as well, because
Also,
I think that's yeah, go on.
No, Karen.
No, just I think that I'm mindful of, actually it was the ICPCN conference in Buenos Aires some years ago now, but it was a GP colleague who said palliative care scars us, but we bear the scars, so with pride, I guess, but we should, it can be seen as a very not a very happy or not very kind of hopeful place to be, but I think I would say much more the humbling and the kind of, for me, is the parts of my nursing care over the years which I'm most proud of, and which are most kind of satisfying to know that you got it right for that family at that time. And that's always kind of say that to students, is that there is a pressure in that, because you can't rewind and go, okay, let's just do that slightly, once it's done, and families will live with that, I think, in the kind of grief for many, many years to come, and you can't undo it, so you do have to get it right, but when we do get it right, I think it's one of the most satisfying things.
It's also interesting in that probably just the way the word cloud has has come out, but it's got painless next to painful, and this is one of our challenges, isn't it? That there's the thought of it being painful, the thought of the pain that children and their families are in, but we want it to be, we want to relieve their pain, we want to relieve their suffering. And so these two kind of opposite ends, if you like, of the spectrum, that are both key in what we're doing.
Yeah, and that that difficulty of, can we always relieve pain, and the different types of pain. I think there's we'll talk about the symptom management chapter, which is huge, and a very, very difficult chapter to write. Sue can't be with us to led on that chapter, but yeah, that dealing with that, where are the boundaries of what we can do, and where sometimes we have to kind of still be present, but we may have to kind of accept that there are limits to what we can do. And so, yeah. Anything else, Julie, before I move on?
No, I think it covers quite a lot in there, really.
Yeah. Timeliness, that sounds a good one as well. Cool. So we wanted to start with this kind of idea about which might be the best ways to help nurses to learn that palliative care is everybody's business. So have a look, and I think you can vote for more than one if you want to.
Duncan, just to say that one or two people are having trouble voting, so they're putting their thoughts in the chat box.
Cool. That's great, because they'll all be captured, which will be grand.
Yeah.
So yeah.
Thanks, Alison and Concepcion.
Fabulous. So we go to chat. What sort of thing? What's in the chat?
In the chat, it's talking about some words from the previous section. So holistic,
Okay.
child, family-centered, collaborative, fragmented, memories, family support. Many of these were included in that word cloud.
Cool. Yeah. So this is, I think, drawing a map of network of people is coming out as a favourite, and so I think that Katrina's on the call, I know. So Katrina, you can talk to this better than I can, really, about compassionate communities, and the ways in which I think it came out in some work that Julia and I and Katrina have done around the principles of public health, palliative care, and this is kind of a realization that in Western high-income countries, we have a professionalized kind of service, but that in low and middle income countries, actually, that much of the work is done by informal carers, and so it's often referred to as the carer model. So I think actually that kind of understanding the team around the child, or the network of people around a child, is a really important kind of thing to do. Yeah.
Duncan, it's Katrina, just to sort of
Hello,
say
Katrina.
one of the things around when you do the map, it's quite interesting if you as a professional do the map. It's also really interesting if you ask the child or the young person who's important to them, and then compare that to your map. Have you got the people who are really important on that map? You can then add in the parents' views of who's important, who provides them with most support. It's quite often grandparents. And then you start going back to asking grandparents, and that map becomes really, really busy. So just to sort of say that, it's interesting to do it from our own professional perspective, but if you start doing that from the family perspective, we can learn a lot and make sure that they're involved.
And you're adding in a lovely element there, of how important people are to the child within that network. So there is kind of software, I think, and ways in which you can kind of scale that to show the network as being not just nodes that have all got equal kind of, but like larger nodes and smaller nodes. So there's certainly in network theory a lot of that ways of trying to show how different the nodes might have different levels of importance, which I think would be really kind of interesting in that, wouldn't it? Yeah. I guess that's the thing about doing an interview. That'd be okay, but as you say, I think that depends on skills of people interviewing to get to a carer's perspective, or the child's perspective. So we have a thing called Peer at Bournemouth, and we just literally a few weeks ago did a service user, people who use services day, in which young people and people, carers, come in and talk about their experience of receiving care, which is a big mind switch for the students around very different perspectives that people have on care. So yeah, I don't know if people have experiences of doing death cafes. That could be another way of taking it outside of a professionalist kind of framework in which people are very kind of equal. So certainly the ones I've done, we've used World Cafe, Brown et al, to kind of to get an atmosphere in which people come in as equals rather than a kind of professionalized way of looking at it.
Duncan, there's a comment from Lisa in the chat saying a parent of a child in the south has created a mind map of all the professionals and teams involved with his child, which has been woodenly shared at conferences and in triaging, and he's been very effective at describing this point visually. And yes, there's some really clear visual portrayals of the interconnectedness and the vast network of people involved.
I wondered if you wanted to comment on organisations and institutions, and that goes like leadership in palliative care, maybe.
Yeah, I mean, it's an interesting one because it's interesting how many institutions or organisations don't have a policy on palliative care for children. If it's a paediatric hospital or hospice, and obviously they do, but generally they're what we found, and I should have said in my introduction that I've been working internationally for the last 25 years in the development of palliative care and children's palliative care. So often there is either no policy or there's a policy on palliative care that doesn't necessarily include children, and in many places it's not always encompassing. So if you do find in an organization's policy the importance of children's palliative care, the encompassing nature, and how it is everyone's business, then that's really good, because we've done some reviews of policies and that's often missing. So it's a challenge having the policy that links in with the practice and vice versa.
I think it was one of the things that came out from the early CPCET groups, and we kind of use the hospice gardeners as our example. So there's people, like lots of children's hospices will have a remembrance garden or lovely gardens for people to go and sit in, and that's where parents go to kind of reflect. But nobody had thought that the gardeners who are interacting with parents need to kind of understand that. So that's really where we had a public health level, and then we had a universal level, and that was to say there's a thing about projecting children's palliative care out to communities, and to have a public understanding of child death, which is so important. And I think we really need to kind of learn the lessons that we had from the Liverpool Care Pathway, which is about taking people with us, taking communities with us as we develop palliative care. but also that there's this universal, which is actually lots of the people who support us in our work, who might not be professional in that kind of sense, but actually interact with parents and children quite a lot, and actually giving them some skills and understanding to interact with somebody who's grieving, or understand and interact with somebody who's really angry because of what's going on for them, is a really useful thing to kind of do. And so yeah, I think that was kind of where this was at the kind of public health universal level. If that's okay, should we move to the next one? How best can we help nurses to care for themselves when delivering palliative and end-of-life care? Give them some time off. That'd be nice, wouldn't it? Or should you be forced to do something outside? Opportunities for group reflection, early leader there, and social activities as a team. I think this is in here because as we developed the education standards, we came to realise that we really needed to build in self-care for nurses, that actually what we're asking people to do is difficult, and so they needed to have an understanding of the personal costs, professional costs of delivering palliative care, to enable people to survive and to enable people to be, I don't know, resilient is, I don't like that word really, but we'll use it anyway. So grand, yeah, I think so. I think social activities as a team is a nice one, isn't it? That's whether that team coefficient, I think team working is so important, and that came out in the standards as well, about your self-care, but also your understanding of your presentation in the team, that you how you present yourself in the team could give problems for other people, and so you have to kind of do that. But yeah, I think some of these things I think we probably all hold personal responsibility for as well, so that those are ways in which we can self-care. I went for my run this morning, which is part of my self-care. So even though I didn't want to, it was very cold, but I know that kind of helps me to stay fit, and that helps me with kind of all of those things. But the opportunities for group reflection is an interesting one, I think, in the agenda for clinical supervision, which I feel within British children's nursing has never really kind of taken off. I don't know, Julia, whether internationally other countries have more clinical supervision in palliative care. If it's a thing, no. Okay.
It varies from place to place. It really does vary, but yeah, it's certainly in a couple of places that I've worked across Africa, we put in clinical supervision, and it wasn't really utilised. So that the teams were finding other areas, other ways of perhaps more informal supervision and reflection. And I think the social activities, working together, talking things through as a team. But then I think this is also, all of these things are also about the type of individual we are, aren't they? Some of us are quite happy to reflect as a group and openly. Others would prefer to just go for a run and run it off and think things through themselves. So it's about ensuring that there's different ways that we can support team members.
Yeah, and I think that I often think that in practice, where what we might say that every nurse needs to be able to deal with palliative and end-of-life care, but you don't necessarily need to do it today. And so certainly for us, when we have students, it might not be a good time for them in their course to be doing the unit in which we look at palliative and end of life care, because they've had a death recently or those sorts of things. And I think informally we deal with that, and we kind of give students extensions, or in the unit I run, there's an alternative scenario which does have some palliative care elements to it, but not half as much as the child with a brain tumor. So they can kind of they can have a less of a kind of input. It's a more of acute dying situation. So if there are ways in which you can kind of informally we do that, and I think in clinical practice I've certainly seen that, where people will say, I can't do it today, it's not for me, and I think as a team we would always rally round and make that happen. But I'm not sure that formally it's kind of recognized that, as you say, I think sometimes it's about where you are at that time. And that's okay as well, that we should have that ability to kind of say, actually at the moment I'm not in a good place to be entering into these therapeutic relationships, because it's not, because other things that are happening in my life, and because we're all human, and that should be fine, shouldn't it? But I'm not sure formally how we recognise that, and certainly that within contracts and industry and things. Should we go on to the next one? When is it best for children and their carers to be referred to a specialist care team? So upon diagnosis. Sorry, there's a typo in there. Sorry.
Whilst they're doing this, there's been discussion in the chat, Duncan,
sorry, thanks, Julie,
around. No, there's been discussion around what is a death cafe, and Katrina has answered that, about it being something that brings people together to discuss death, to increase awareness of death, and very often they're held in local areas during Dying Matters Week. So thanks for answering that, Katrina.
They're great. They're very interesting and stimulating to take part in. I would say just be prepared for just about everything and anything, because when I've done those events, I've had all sorts of things that adult conditions and all sorts of things that people want to discuss, which might be kind of quite difficult to you have to really know your whole kind of spectrum of nursing to be able to go, okay, that doesn't sound right. You definitely need to see a GP. Yeah, cool. So I think this classic answer is the most popular, isn't it? Upon diagnosis.
Alison's just put that in the chat as well, so we've got that another one to add.
Yeah. I think so we were doing some work recently with Lewis Manning Hospice, which is an adult hospice in Dorset, and they've done a programme of looking at adults with palliative care needs and putting in hospice care much earlier, and that has really facilitated the staying at home, not having as many emergency kind of consultations, and being really helpful. And I think there's certainly the work from the States that putting palliative care in early prolongs life and improves life expectancy, which is kind of like a bit counterintuitive, I know, but actually that's kind of really useful. I guess the difficulty is knowing when we move from that life-limiting diagnosis as to being threatening and to needing to being accepting of palliation. And I think that's a bit of the, sometimes a bit of the stumbling block, is that people feel, oh well, actually you need to be, you know, that if we refer to palliation, that's giving up, or that's, you know, you're not looking for cure anymore. And so I think that right back in the early word cloud was parallel planning, and that's a really useful kind of thing, I think, to think about. It's not about, right, we're just switching completely over to palliative care. We're able to run both these opportunities and both these kind of outcomes, possibilities, and at the same time.
And I think that's what's often challenging for people, is that those two do run side by side. And that's, I think, also one of our challenges sometimes as nurses. We've, I was thinking, we were discussing just the other day with a colleague who was saying, well, the mother doesn't, she's just not accepting that this child is dying. And what was happening was, you know, she was having one day, she was talking about taking her home so that she could die at home, and then sort of almost 2 hours later she was talking about, well, when she's grown up. And those two things as well often go parallel, don't they, hand in hand, when you're walking along that journey. And so those two things around hoping for the best and planning for the worst is so important.
Yeah, almost like dual processing theory.
Yeah.
Pre anticipatory dual processing theory. Dual processing theory is the theory of grieving, that people run their normal lives alongside their grief, and that you can actually have grief crashing in on your attempt to continue with your life, as rather than a kind of staged approach where you get over the grief at some point. Dual process theory says it's kind of carries on for much, well, just carries on, and it's always going to be a part of who you are. You carry your grief with you, and so I think it gives us a different kind of aspect of thinking about care interventions. So if there's a staged approach in which we work through the stages with people, we would come to a kind of end at some point, and we'll say, oh, okay, well, we've done, you know, that anticipatory grief work with you. But if it's a dual processing thing of that's content continuous, and you wouldn't have an end to it. It would always be possible to be then having both these possibilities at the parallel running at the same time, and having to kind of support people with that. I just recently reviewed a paper, very, very good paper, and it was on organ donation. But so it was asking parents about organ donation in childhood, and looking at the kind of barriers and challenges. But one of the interesting things, I think, was that often their reason for not donating tissues or organs was because they had they planned their end of life care, and the organ donation wasn't part of what they were doing. So I guess it's just a bit of a kind of a plea for us to build that in somehow, because I think that certainly other work I've seen and what we've done, that the benefits from being able to feel that your child continues to live, or their heart, or their, you know, whatever it is, a part of them anyway continues to live, is very, very it is sustaining for some people. It's obviously not for everybody and not every circumstance, but I think it's in reviewing the paper, I had to go back and think, well, where did we build organ donation in? And I'm not sure we have really. So yeah, and that's active dying. Yes, that's. I think we threw that one in as a bit of. If you've spotted it as being the one that's really very tricky and difficult, that I'm not sure many of us would know quite what active dying or what passive dying would be then. but yeah, and I think that's kind of the interest. One of the interesting things when we were writing the management of symptoms for the book, I don't know that we actually kind of really got to it in the end, but part of the kind of complexities that we tend to think of symptoms in isolation. We tend to kind of think of pain and fatigue being different things, but actually it would be useful to think about them as interacting with each other. That nausea and pain and fatigue might all be related, and so we tend to kind of think about managing symptoms, and we've done it in the book as well. We've kind of put it into body systems because it's a lot easier to do it that way. And so the complication bit is I think an area for us to develop a little bit more, I guess, and that would definitely relate into the social problems as well, that tend to be kind of exacerbated in palliative care. The divorce rates amongst parents who have a life-limiting, life-threatening are huge, which I think is another area of kind of difficulty, really, about how do you sustain relationships. And some people do. Some people, it actually improves their relationships, but for many people, it shows issues that might have been there before as well. But definitely makes things difficult. I think one of the things is that most of what we consider in palliative care is around planned palliative care. So where we know we've got a diagnosis of a life-limiting or life-threatening condition. I think, Julia, you and I would probably go to Richard Haynes' work, though it's not got everything in there. There's some limitations to it, but even so, what is a life-limiting, life-threatening condition? Where Richard Haynes has a directory of conditions using the International Classification of Disease, and so that would be really helpful. So, but then you've got planned kind of palliative care. And I think where there's less understanding, less research, is where we have a sudden death, where we have, those kind of situations. There's a lot less written about that. There is some, I know, and I know colleagues in Birmingham who've done some of the work on that, but there's a lot less in palliative care. The interesting thing is that a lot of the literature in palliative care is still around cancer, although it has changed, it is moving than that. But in terms of palliative care, it's quite a distinctive journey in cancer, in that you tend to find that they don't use hospice services because people are looking to cure until the point at which it becomes obvious, and then so it tends to be a very quick and sudden death in many circumstances. Julia, you're the cancer expert, not me, really. I don't know what I'm talking about, but I think that there are for those different conditions different kind of dying journeys, aren't there?
Yes, different trajectories for the different children, but it's not just the different conditions, but it's also what treatments do you have available, what resources do you have available. So it's an interesting and challenge, and that is all in the Together for Short Lives, in their guide to children's palliative care, that looks at some of that as well, and the trajectories and things. So that's worth looking up. I think I've just put a resources link for the ICPCN website, and many of those resources are on there, and the Together for Short Lives website as well.
I think that nicely brings us into our ICPCN map.
Yeah. So I think it's been interesting because after this, we'll just briefly mention the development of the education and training standards and the book. And I think both of those initially started out being more focused on the UK, but then as we worked on both of them, it's really important that we think about the the global context. So just trying to put what we do in the UK into perspective of the global situation. So there's over 21 million children globally who need access to children's palliative care, and the estimations is that only 5 to 10% of those children have access. So there's 19 million children and their families around the world who can't access children's palliative care, and there's lots of reasons why they can't access children's palliative care. A lack of education is one of them, and thinking about the education and training standards and how those from that have been developed within the UK context, but how some of those can be adapted and utilised. So one of the things as the International Children's Palliative Care Network is that we don't want to be reinventing the wheel. So what resources are there from the UK that can be adapted internationally? What resources are there from Uganda that can be adapted for the UK, etc. And so really learning from each other. But there are still many countries where there is no known children's palliative care services. And so this map, and we literally just submitted the paper for publication this week, this map shows we want to change the world to dark green. And the very pale green is where there's limited or no known children's palliative care services. And so you can see that places like the UK are really doing well. Now, I know people in the UK say, well, it would be great to have a bit more coverage for children's palliative care, and not all children and their families can access that. But the diversity between different countries is great. And so how can we learn from each other? And I think when we looked at developing their children's palliative nursing care book, we did purposely brought together people from different countries to write the chapters, which was really important as we learn from each other. And we wanted to have a book that was thinking about children's palliative nursing in different contexts. So hopefully that leads on, Duncan, to the next, just the last. It's 10 to 5, so we've only got a few minutes.
I'm going to be speed doing this bit.
So just
very speedy to allow the colleagues some. So there's links in that we'll share these slides with the team. So there's links to the standards that we've talked about, and this is the how we put those standards into the book that Julie's already kind of mentioned, really. And so that's right. One of the useful things I think was this 4 kind of levels that we tried to get in there, which is around, I've talked about public health and universal, and the core is what we think that every nurse should be able to do, and specialist is for specialist kind of nurses, but they come across these 4 kind of learning outcomes as well. So communicating effectively, working with others and across various kind of settings, that's huge for us, isn't it, around community and hospital and hospice. Identifying, managing symptoms, and sustaining self-care. And so some of these we've kind of talked a bit about.
Can I just add, Duncan, one of the key things about this, if you go back to some of the other literature, so the World Health Assembly resolution on palliative care, the EAPC competencies for children's palliative care, a lot of them often only have 3 levels. And so importantly, within this, it brings in the public health level, and that is an area which is often missed. And so that's really key for this standards framework.
We purposely kind of wanted people to move through the levels. So really to do core, you ought to have done public health and universal first as well. So although there's stuff in core that stands alone, the vision is really that to get to core, you would have had to have done the other two. And so, yeah, so these are some of the things that we put in, and I think some of them were things which I didn't kind of think about, and it was colleagues that the action group who really kind of helped the legal and the care of the body after death was a really big thing, which we didn't kind of necessarily think about until we got that. But being able to manage common symptoms and being able to evaluate care and symptom management, and yes, into bereavement really. We had those kind of those are in the guide. So again, as I say, one of the interesting chapters was chapter 6. This was a really hard chapter to get anybody to write, and so for various kind of reasons really, but it would be really useful to pick up on that play education in palliative care is not something that we have a great depth of research understanding on, in which we could kind of tap into. There was not that many experts around the world that helped us. Unwanted news,
but also, so
yeah.
Duncan, just adding on that one, was that we were very keen with this book that it was written by nurses for nurses.
Yeah.
So there was some people who could write the play education section, but they weren't nurses, and we really wanted this from a nursing perspective.
And I think also the thing that we all set ourselves up with people from lower income countries and high income countries, and then that made it some of it quite tricky and quite challenging as well. But it did give a different perspective. So Angela works in South Africa, so some of the things about actually you don't need resources, you can play with very minimal kind of things. So we have got papers into a few conferences coming up. There is another webinar if you'd like to join on the 20th of February, and we'll be talking more about palliative, children's palliative public health, the public health stance on children's palliative care, which is kind of really interesting, and I think we're hoping to move forward with more about collaborative communities as well, and compassionate communities, I guess. So that's us. There's a link there to the book if you'd like to buy the book, or have it in your library, whatever. Thank you very much. I'll stop sharing there. I don't know if anybody's got questions. We've only got 5 minutes left. I know, sorry. We did say it was a huge subject, didn't we?
Thank you, Duncan, and thank you, Julie, for that presentation. I know there's been some comments made in the chat as we've been going throughout, and I know some of them have been answered as well. So I don't know if anyone had any more questions at all. I can't see any hands up at the moment. I really like the Mentimeter stuff. I think as a way of getting kind of direct information from people about, especially around the word cloud stuff, I think that's really beneficial to some of this, and I'm guessing more so as well from a research and kind of academic background as well. Mentimeter has altered the way you can get feedback directly from individuals as well. So
yeah. Jean's got a hand up.
Jean.
Simon, yeah.
Thank you very much, Duncan and Julia. That was really great. I work at Bangor University. I'm teaching children's nursing students. I have been a palliative care nurse in the past, and you just touched on bereavement at the end there, and there is a consultation at the moment which you may be aware of, looking at the impact of bereavement for young people up to the age of about 25. But it closes tomorrow, and I only came across it today, unfortunately. Oh. So I don't know if anybody else has, responded to it, or, I'll certainly find it and put a response in. but I'm not too sure if you were aware of the origins of that and what we're trying to do with it. Thank you.
Thank you for it. No, not aware of that. I don't know if Julia was, but
No.
no. There's a lot of work going on, which is great. And so it would have been nice if we could have agreed a tariff and been paid for the work that people do. But there we are. Bernie might know more about that survey. No, she doesn't.
No, she's shaking her head.
Sorry, Bernie, put you on the spot.
I'll find
I wasn't
it
aware
and
either,
post
yeah.
it in the chat if that's okay with everyone. I'll find it. It'll be in my history now in the computer, so I will post it in the chat if that's okay.
Yeah.
Thank you.
A couple of things we've done recently, which has been quite effective as well with nursing students, is having some nursing students from Uganda joining some nursing students in the UK and discussing some of these issues. So like the whole grief and bereavement thing and the cultural context and things like that. So I think one of the exciting things about the increase in virtual training such as this is that we can bring people together from different backgrounds, different parts of the world, studying similar things and looking at it from different perspectives, which obviously working internationally I find really valuable.
And Together for Short Lives has just relaunched its education network, which is fantastic. There's lots of really active palliative care nurses in that network. So we did a similar presentation to them January, that was. So yeah, hopefully that having been relaunched will kind of start to pick up momentum. And there is Together for Short Lives conference in Manchester. I think it's in May.
In May, yeah.
Yeah, we have got a paper into it, but the dates now.
We've got one in Manila in November, if you fancy
yes.
Manila in November. It's a bit further to go.
But
It's not that far away.
They're always excellent. I could say I went to one in Argentina, and it was fabulous, really different for a conference, because I think you walked around and nobody said what their background was. Nobody said I'm a doctor or I'm a physio or I'm a social worker or whatever, or a priest. It didn't matter, and nobody cared. And so you actually got to talk to people and find out lots of really interesting stuff. So if you can get it into your budget to get to Manila, then that would I would highly recommend it.
Katrina, you and Peter visited when we had our first one in Mumbai, and you and Peter visited Kerala and things, didn't you? So you were able to use it as an opportunity to learn.
I think that was, I mean, with all of the ICPCN events, that gives you a real insight into the reality of care, and you're hearing it from firsthand. And yes, Peter and I went to Kerala. We thought they were amazing in India, and when we were writing our chapter on compassionate communities with two nurses from India, it was really interesting because they thought we were fabulous because we'd got lots of children's hospices. We were saying, no, that's unsustainable. What we need is what you've got. But it's that opportunity to learn from people from completely different backgrounds, because sometimes we get stuck in our boxes, don't we? And I think international working gives us that opportunity to look at things from a different perspective. So I'd certainly recommend, if you can get to Manila, I mean, Manchester's okay, but Manila's great. But also maybe taking part in some of the webinars that ICPCN do put on quite regularly, because it gives those different perspectives and helps think differently.
Brilliant, thank you. And one of our other up and coming webinars is around sexuality and life limiting young people, and which is great to see that that's still going. I started that Sexuality Alliance as a co-chair with Maddie Blackburn at the time, and that was on some back of the work that we started at Rainbow's Hospice in Rainbow's Children's Hospice in the East Midlands.
And they've had a book out as well, haven't they,
and
last
a book,
year?
And and the Sexuality Guidelines is amazing piece of work that they've completed. So and I think it's had its second or third review now. So that program has been fantastic, and the engagement and input from young people was amazing. And I could talk about sexuality, and the stuff we did at Rainbow's Hospice for our young adults when we opened the young adults unit was just out of this world. But unfortunately, the money's gone, so it's gone back down to up to the age of 18. But it's such a but the transitions work that's been going on, the preparing for adulthood work again is still amazing. That's going on across the country. So yeah.
Can I just thank Julia and Duncan really on behalf of the ABPN, because ABPN, and we haven't mentioned it as yet, but ABPN were involved right from the start with that framework, because there is that recognition that we needed resources, and this was seen to be a really important resource. So it's great that we've continued that over the years from pre-COVID days to now, and to have a resource that will hopefully be helpful around the world. So thank you for sharing it. And yeah, there's lots of sort of signposts to other places in the chat box, which is great. Thank you.
No worries. Lovely to see you all.
Thank you, everybody, and we'll see you at the next webinar.